All right. Hi, everyone. I'm Julie Creech. I will be your moderator this evening for tonight's installment of the AMSSM National Fellows Online Education Committee's National Fellows Online Education Series. So tonight we're going to learn about exercise in pregnancy from Dr. Eziamaka Obunadike. But before we get started, let me just kind of remind everyone of our basic ground rules. So as I mentioned, this talk and all talks in this series are sponsored by the Online Fellows Education Subcommittee, as well as the AMSSM Education Committee and the AMSSM Fellows Committee. The purpose of tonight's discussion is just to help supplement your current program's education, as well as help assist you become not only a well-rounded sports medicine physician, but also prepare you for your CAQ examination, which is coming up. Throughout the course of tonight's presentation, we ask that you turn off your cameras and mute your microphones. Additionally, we do encourage questions. So if you do have questions that arise throughout tonight's presentation, please feel free to message me those in the chat function, and then I'll ask them at the end of the presentation. So without further ado, I'd like to introduce our speaker tonight. Our speaker is Dr. Eziamaka Obunadike. She is a sports medicine physician within the Department of Orthopedics and Sports Medicine at Emory University. She completed her medical education at Duke University School of Medicine, her internship and her residency at Harvard University, and then she completed her fellowship at Emory University. She is board certified in physical medicine and rehabilitation and is a member of the American Board of Physical Medicine and Rehabilitation. Dr. Obunadike has special interests in musculoskeletal ultrasound, stem cell and PRP therapies, and, appropriately so, women's musculoskeletal health. Additionally, she serves as one of the team physicians for the WNBA Atlanta Dream. So I will go ahead and turn over the screen to Dr. Obunadike and let her teach us some more.
All right, let me share my presentation. All right, let me minimize this screen. Okay. So good evening, everyone. As Julie mentioned, my name is Dr. Eziamaka Obunadike. It's a pleasure to have been invited to give this talk to you all on exercise in pregnancy. I hope you all find it informative and it stimulates some ideas for potential research projects and also potentially helps some aspect of your clinical practice. So I have no disclosures. So the past decade has really been transformative for the pregnant and postpartum athlete. There are so many examples like beach volleyball player Kerri Walsh Jennings, who won her third gold medal at the 2012 London Olympics while she was 5 weeks pregnant. We have three Williams winning the Australian Open in 2017 while she was 2 months pregnant. Felix breaking Usain Bolt's record for the most track in 10 months postpartum. Swoops announced that she was pregnant before the inaugural season of the WNBA and returned to her sport 6 weeks postpartum. I think what's so great about this is that not only are elite athletes, but women of all levels, including recreational, exercising more during and after pregnancy. This is really allowing us in sports medicine to evolve our understanding of how musculoskeletal and physiologic changes that occur with pregnancy and postpartum can change performance, sports, and general exercise guidelines and recommendations. As more women are participating in exercise during pregnancy, we'll be able to learn more and more about what effects and upper limits of exercise on pregnancy and postpartum. All right, so I wanted to first talk about just what is pregnancy. So a normal pregnancy lasts about 40 weeks from the first day of your last menstrual period. Pregnancy is assumed to start 2 weeks after the first day of the last period. Therefore, an extra 2 weeks is counted. So thus pregnancy officially lasts about 10 months, which is the 40 weeks, not 9 months like is commonly described in the media. The 40 weeks of pregnancy often are grouped into 3 trimesters. So the first trimester starts with the first day of your last menstrual period till about 13 weeks and 6 days. This is the time when fertilization and major organ development occurs. The second trimester is usually described as 14 weeks to 27 weeks and 6 days. And this is a time of rapid growth and development of the fetus. The third trimester is considered 28 weeks to about 40 weeks and 6 days. And this is the time when the fetus weight increases and the organs mature so that they will be ready to function after birth. So for a healthy pregnancy, a woman's doctor's appointment schedule will consist of 1 prenatal visit a month from weeks 4 to 28. So basically from the first and second trimester. And the third trimester from weeks 28 to 36, 1 prenatal visit occurs. 40, a female will have 1 prenatal visit per week unto delivery. So in the next few slides, I'll go over some of the musculoskeletal changes that occur during pregnancy and describe how these changes affect posture, balance, gait, joint stability, and risk of falls during pregnancy. So we'll start with spinal posture. Pictured to the left is the spine in the normal state. So you have your cervical, thoracic, lumbar, and pelvic aspects of the spine. If you move to the center picture, this really depicts the 4 natural curvatures of the spine, as we know it: the cervical curvature, lordosis, thoracic kyphosis, the lumbar lordosis, and the sacral kyphosis. So these curves are going to be very important to note as they are all increased during pregnancy. So down to the right, this picture depicts some of the key compensatory changes in the spine that take place during pregnancy. Starting with the top of the spine, the head shifts forward, worsening the cervical lordosis. Then to not only accommodate the expanding uterus and fetus, but also to preserve pulmonary function, the rib cage has been known to expand laterally by 10 to 15 centimeters. This can be associated with complaints of rib or costochondral pain during pregnancy. Also with pregnancy, you have an increased breast tissue with this constrained rib cage. So this exaggerates the thoracic spine extension or worsens the kyphosis. The pectoral muscles shorten in response to these postural changes, exacerbating depression and rounding of the shoulders. So to accommodate the expanding uterus, moving down to the pelvis and fetus, as one progresses through pregnancy, the center of gravity shifts forward. So if you look at this picture here, the first 2 models show the normal lumbopelvic posture and center of mass. Then the next models really show the anterior displacement of the center of mass, which increases the anterior pelvic tilt. So if we now look at this far right picture, this shows a compensatory increase in lumbar lordosis. So specifically, this increase in the anterior pelvic tilt results in compensatory recruitment of the lumbar paraspinal muscles to stabilize posture and thus worsening the lumbar lordosis. Okay, so as we move to the lower limb and look at the knee and feet, these also undergo many changes in pregnancy. So we'll start with the feet. As ligamentous laxity increases during pregnancy, this results in a reduction in the height of the medial longitudinal arch, and thus subsequently leads to worsening pes planus, or as we know, flat feet. So this is basically an increase in the length and width of the feet. So now looking at this picture to the right, this compromise of the medial arch leads to increased pronation of the feet. So basically an inward tilt at the ankle then occurs. As the foot pronates, this also leads to further increase in the anterior pelvic tilt and internal rotation of the tibia. This internal rotation of the leg leads to stretching of the knee ligaments and the IT band. So because of this, especially the knee's reliance on ligamentous support, they compensate by progressing to an hyperextension state or genu raccovatum. So in addition to the static changes to the body that occur during the pregnancy that I just discussed, there are also changes in gait and balance during pregnancy. So there's a widened stance, or the width between the feet, as one progresses through pregnancy to increase the base of support. So this improves both balance and reduces side-to-side postural sway. Most women see a decreased stride length between the second and third trimesters. So stride length is defined as a sum of the left and right step lengths, as pictured there. There's also an increased time during the gait cycle spent in double support, likely to compensate for the increased hip abductor strength needed during single limb support in pregnancy. And finally, there's an increased step width during pregnancy that contributes to greater lateral displacement of the center of mass. This is a gait pattern commonly characterized in pregnancy as a waddling gait. So now I'm going to discuss briefly the hormonal changes that occur during pregnancy that influence both the neuromusculoskeletal system. So these include 4 main hormones. You have estrogen, testosterone, progesterone, and finally, relaxin. So the 4 main hormones related to pregnancy are listed on the left of this table. We're going to focus on estrogen and relaxin, which are highlighted in red, and their influence on the musculoskeletal system, which essentially is to increase joint laxity and ligamentous laxity. So this process to increase joint laxity and ligamentous laxity is largely to get the pelvis ready for a vaginal delivery. However, as you can imagine, hormones act throughout the body. Thus, this joint and ligamentous laxity is a systemic process. So for many women during pregnancy, they will have increased motion at the SI joint, at the pubic symphysis, and this leads to increased low back and pubic pain that's common in pregnancy. This is essentially key for rehab because as during pregnancy, the main focus in terms of managing musculoskeletal issues is going to be on joint stability exercises. So the musculoskeletal disorders in pregnancy is a vast topic, and we don't have time to go into that today. So of all the physiologic systems, the cardiovascular system really takes on the most profound adaptation in pregnancy to support fetal growth and development. So pregnancy really is like a woman's biggest life cardiovascular stress test, meaning that shortly after conception, women experience profound adaptations in the cardiovascular system. So these are listed on the far left of this chart and include increased heart rate, increased stroke volume, increased cardiac output. Blood pressure is really negligible in terms of its change throughout pregnancy. You have decreased vascular resistance, increased systemic artery enlargement. You have reduced cerebral blood flow velocity. So several studies in Canada have found that about 6% of all pregnancies are complicated by maladaptations of the cardiovascular system. So this includes gestational hypertension, preeclampsia, eclampsia, HELP syndrome, which is defined as hemolysis, elevated liver enzymes, and low platelets. So this incidence increases with age. So usually it's higher in women 35 and older, and also in patients who have a pre-existing condition such as diabetes or obesity. From a respiratory perspective, the progressive uterine expansion is a major cause of lung volume and chest wall changes that we see during pregnancy. So this comprises of the elevation of the diaphragm and altered thoracic configuration. So specifically, there's a rise in the diaphragm in pregnancy of about 5 centimeters, with the expanding fetus resulting in a decrease in one's chest height. But this is balanced with an increase in the thoracic dimension to maintain constant total lung capacity and increased tidal volume. So tidal volume being the amount of air that's moved in and out of the lungs during normal breathing. Minute ventilation also increases during the first trimester, which we call that the physiologic hyperventilation of pregnancy. And this is due to the higher tidal volume with unchanged respiratory rate. So respiratory function has been found to not differ whether one is having a singleton or twin pregnancies. So the big question is, should pregnant women exercise? So for most women, the answer is a definitive yes. In fact, there are so many benefits of exercise during pregnancy. One benefit is a higher incidence of vaginal delivery. Exercise also provides a lower incidence of the following: lower preterm labor and birth, lower long labors, lower rates of low back pain, lower rates of excessive gestational weight gain or gestational diabetes, and also lower rates of gestational hypertensive disorders, which includes preeclampsia, gestational hypertension, and also lower rates of depression. So it's really like, why wouldn't women want to be recommended to exercise? Why wouldn't women want to or be recommended to exercise? There have been no studies really that have found exercise to be detrimental to the fetus in a healthy and uncomplicated pregnancy. Although some modifications to exercise routines will likely be necessary, either at the start or as a woman goes through pregnancy, this is because of the normal anatomic and physiologic changes and fetal requirements that occur with pregnancy. So it's also important that I define what is exercise. So exercise is defined as a physical activity consisting of planned, structured, and repetitive bodily movements done to improve one or more components of physical fitness. So it's an essential component of a healthy lifestyle. So now I want to go back and discuss how the guidelines regarding pregnancy and exercise have evolved. So in the spring of 1985, the American College of Obstetrics and Gynecologists, ACOG, released the first official guidelines for safe exercise during pregnancy. Due to limited available research at that time, recommendations were conservative and extremely rigid to ensure a safe and healthy pregnancy to the majority of women. So these guidelines consisted of limiting strenuous exercise to no more than 15-minute intervals, keeping the heart rate less than or equal to 140 beats per minute. They also mentioned that previously sedentary women should not begin an exercise program during pregnancy. Obese and sedentary maternal lifestyles were considered relative contraindications to exercise in pregnancy. And lastly, previously active women should reduce exercise intensity to prevent fetal harm. As you can see, for us women of childbearing age, it's very fortunate that these guidelines have evolved over time. So most recently, we have the 2022 Australian, the 2020 WHO, the 2020 ACOG, and the 2019 Canadian, and the 2018 US Department of Health and Human Services guidelines for physical activity and exercise throughout pregnancy. For women without contraindications, they all mirror what we recommend for all adults. So this being 150 minutes of moderate intensity aerobic activity, so that's 3 to 6 METs, over at least 3 days a week, incorporating a variety of aerobic exercises and at least 2 days a week of resistance training exercises. So the key is a diversified and well-rounded exercise program. There is some literature looking at pelvic floor muscle training. So for example, Kegel exercises. And so these can be performed on a daily basis during and after pregnancy to reduce the risk of urinary incontinence postpartum. there's a lot of, there's just a limited amount of research in this area, and the ones that are present are pretty weak and show low quality evidence. But Kegel exercises and pelvic floor muscle training is definitely an important factor to always keep in mind. So essentially, the exercise goals in pregnancy should be to maintain or develop good fitness levels throughout pregnancy without trying to reach peak fitness or train for an athletic competition. So now the question is, when should a pregnant woman not exercise? So there are some absolute contraindications to exercise, meaning one can continue with their usual activities of daily living, but should not participate in more strenuous activities as the risk of exercise outweigh the benefits. So some absolute contraindications include hemodynamically significant heart disease, restrictive lung disease, and incompetent cervix or cerclage, multiple gestation at risk of premature labor, persistent second trimester or third trimester bleeding, placenta previa after 26 weeks of gestation, premature labor during the current pregnancy, ruptured chorioamniotic membranes, preeclampsia or pregnancy-induced hypertension, and severe anemia. Relative contraindications refer to conditions in which risk may exceed benefits of regular physical activity or exercise. There's a lot of gray in this area, but specific relative contraindications to aerobic exercise during pregnancy include anemia, unevaluated maternal cardiac arrhythmia, chronic bronchitis, poorly controlled type 1 diabetes, extreme morbid obesity, extreme underweight, so BMI of less than 12, a history of extremely sedentary lifestyle, intrauterine growth restriction in current pregnancy, poorly controlled hypertension, orthopedic limitations, poorly controlled seizure disorder, poorly controlled hyperthyroidism, and being a heavy smoker, which has been described as smoking more than 20 cigarettes a day. So in December of 2020, Mia et al. Published a systematic review looking at studies, available literature indications. What they found was that the majority of pre-existing or pregnancy-specific conditions known as contraindications were based on expert opinion, and there was minimal empirical evidence to demonstrate harm of exercise and benefit of activity restriction. So there was also found to be no evidence in the literature that banning exercise in these women improves pregnancy outcomes. The other important outcome of this systemic review is that they proposed a new classification for absolute and relative contraindications. And they also provided a call to action, essentially, for inclusion of these women in these contraindication groups in future research and guidelines, and removing barriers to physical activity in these groups of women where appropriate. So let's address this first common myth that centers around the idea that if you do not usually exercise, you should not start during pregnancy. So this myth has really proliferated for many years, but pregnancy is actually an ideal time to start an exercise program, even if you have never really exercised before. This really is the first time in many women's lives that they are under close and regular medical supervision. Many pregnant women make positive health changes during pregnancy, including things like abstinence from things like drinking and smoking. The motivation to adopt a healthy lifestyle or modify behavior is really high, and so thus pregnancy really is a good time for these lifestyle modifications. So although the majority of the evidence base for these recommendations use supervised exercise and physical activity during pregnancy does not need to be done in a supervised setting or with any specific equipment. So previously inactive women who decide to become more active during pregnancy can do so. And the literature really recommends that they start gradually at a lower intensity, frequency, and duration. And they really build up to the recommendations of the 150 minutes per week, 3 to 5 times per week. So going back to that systemic review paper by Mia et al., they provided some provoking data and recommendations based on available literature that the relative contraindications listed that I'll list on this slide no longer should be considered a barrier to being physically active during pregnancy. They state that there's absolutely no evidence to support stopping prenatal exercise. In fact, becoming completely inactive could result in increased risk of adverse pregnancy outcomes. So the relative contraindications that they're saying should be reconsidered are chronic hypertension, gestational hypertension, being characterized as obese or overweight, recurrent miscarriage, having a short cervix, twin or higher order pregnancies, epilepsy, anemia, orthopedic limitations, a history of extremely sedentary lifestyle, and a history of spontaneous preterm labor or fetal growth restriction. They specifically cited multiple studies that have shown improvement in health markers with exercise, even in pregnant women, especially these women categorized with the above listed relative contraindications. So Mia et al. Specifically recommend that modifications of activities, meaning a reduction in intensity, duration, or volume of exercise, be considered over the complete cessation of activity. So I think that these findings really suggest that we may be limiting more pregnant women who we shouldn't be. More research is really needed in this area, but for now, women with relative contraindications are recommended really to discuss the pros and cons of engaging in moderate to rigorous intensity physical activity, or if they have a sportsman who they're seeing. So women with uncomplicated pregnancies are encouraged to really engage in both aerobic and resistance training before, during, and after pregnancy. The key thing is for women to engage again in a diverse regimen of both aerobic and resistance training exercises. So the recommended activities include things like walking, swimming, stationary biking, low impact aerobics, dancing, as I mentioned, the resistance exercises, stretching exercises, water therapy, so hydrotherapy and water aerobics are also great low impact exercises that are great in pregnancy. Some sports or activities carry significant risk in pregnancy for fetal or abdominal trauma or risk of imbalance or falls, and really should be avoided in pregnancy. So these include contact sports, like ice hockey, contact and collision sports like ice hockey, soccer, basketball. They also include sporting activities like gymnastics, horseback riding, where the increased risk of fall is pretty high, downhill skiing, road cycling, and vigorous racket sports. Scuba diving really should be avoided in pregnancy, really due to the inability of the fetal pulmonary circulation to filter bubble formation, leaving them at increased risk of suffering from decompression sickness. When you look at altitude, women living at sea level have been shown to be able to tolerate physical activity up to altitudes of 6,000 feet, suggesting that potentially altitude is safe in pregnancy, but more research again is needed in this area. Data has also shown that women who reside in high altitudes may be able to exercise safely at altitudes even higher than that 6,000 feet. But the data for that is pretty sparse. So in pregnancy, as I mentioned towards the beginning of my talk, heart rate is increased. However, during pregnancy, there's really a blunted heart rate response to maximal exercise compared to the non-pregnant state. So when you're thinking about an exercise prescription, A woman's previous fitness level should always be considered when you're trying to decide about exercise intensity. Common tools to measure exercise intensity include the Borg's rating of perceived exertion that goes from 6 to 20, the talk test, and using a heart rate monitor. So if you're using the Borg scale of perceived exertion, the target rating is about 12 to 14. And so this is in the category of somewhat hard, is suggested during pregnancy. So the talk test is basically like it sounds. It implies that as long as a woman can carry on a conversation while exercising, she's likely not overexerting herself. And finally, one can use a heart rate monitor to produce objective kind of heart rate measures. You would then need to have some sort of modified heart rate target zones, specifically for in pregnancy. So I've included a table of heart rate ranges for pregnant women that was used or described in the 2019 Canadian Guideline for Physical Activity throughout pregnancy as an example. So another myth is that exercise can get one's core body temperature too high, which has teratogenic effects on the fetus. This idea really came from animal studies that showed that hypothermia during gestation can result in fetal malformations or pregnancy complications. So maternal hypothermia is defined as a core body temperature of greater than 103 degrees Fahrenheit or 39 degrees Celsius. Ravinali et al. In 2018, they published a systemic review that assessed core temperatures in relation to a combination of climatic conditions and exercise intensity. What they found is that in all 12 studies that fit their inclusion criteria, no form of exercise on land, in water, or sitting in a sauna did pregnant women reach the threshold for maternal hyperthermia. So basically, the conclusion is that pregnant women can safely engage in exercise for up to 35 minutes at 80 to 90% of their maximum heart rate in relative humidity measuring 25 to 45 degrees Celsius. Water immersion exercise for up to 45 minutes has been found to be safe, and sitting in a hot bath or in a hot or dry sauna for up to 20 minutes, all irrespective of pregnancy stage, can occur without reaching a core temperature exceeding the teratogenic threshold. So there are symptoms that occur during exercise that really warrant termination of the exercise and evaluation immediately by one's OBGYN. So these include vaginal bleeding, abdominal pain, regular painful contractions, amniotic fluid leakage, dyspnea before exertion, dizziness, headache, chest pain, muscle weakness affecting balance, calf pain, or swelling. So I've talked a lot about this first bullet in terms of barriers to exercise during pregnancy. So we know that there's a lack of support, knowledge, there's a fear of doing harm to the fetus. But there are also several other general barriers to exercise during pregnancy that are really important to consider. This includes fatigue, that's generally associated with different phases or different trimesters in pregnancy. There's a lack of time, especially if they have other children or they're working full time. Pain is a really big issue, especially lumbopelvic pain. Okay, so now if we look at a special population, elite athletes. So elite athletes are generally defined as an athlete with several years of experience in a particular sport or sports who has competed successfully against other high-level performers and trains basically year-round at a high level. So over the last decade, elite female athletes have really begun to challenge stereotypes regarding participation in elite sporting activity during pregnancy. So as I mentioned at the start of my talk, many female athletes are pushing against the societal narrative that they should take it easy during pregnancy. So increasing numbers of elite female athletes who reach their peak performance in their 20s or their 30s, which is common, are wanting to really continue competing during these same years of optimal fertility. So although extensive research supports the safety and benefits of prenatal exercise, these data are really primarily limited to the general obstetric and recreational athlete population and not to our elite athlete population. So current exercise guidelines outline about 150 minutes, as I mentioned, of moderate intensity physical activity each week. However, these are really conservative recommendations and don't really serve the elite athletes who commonly exceed these recommendations, sometimes even daily during their training. The 2016 International Olympic Committee published some general recommendations for exercise during pregnancy and after childbirth. But despite these recommendations, there's still a significant lack of high quality evidence specific to the pregnant elite athletes, and especially the impact of high intensity exercise and extreme doses of exercise during pregnancy on maternal and newborn outcomes. So exercise guidelines, if we now look at the postpartum period, is significantly more scant than exercise guidelines during pregnancy. On top of that, there's not really a consensus on what constitutes the postpartum period. So most people think of it as the 12 weeks post-delivery, also known as the fourth trimester. Others suggest that the postpartum period should cover the duration of breastfeeding, which for some mothers can last 12, 18 plus months. So the postpartum phase is indefinite, essentially, and the guidelines for postpartum return to exercise are also very unclear. Most women will have a visit to their OB/GYN about 6 weeks postpartum and essentially will be cleared to return to exercise. But if we think about it as sports medicine physicians, we don't do this for any other major musculoskeletal event. And I think pregnancy should be considered a major musculoskeletal event. It's in addition a major reproductive event, but nonetheless still a major musculoskeletal event. There are some women who are able to return to sport and exercise prior to the 6 weeks, but the majority take longer. The women that end up in a practice like mine have been cleared and have tried to return to exercise, whether that's running, whether that's playing contact sports, swimming, etc., and then are having pain or some type of musculoskeletal issue that's hampering their ability to return to exercise. So this is something that I myself and others are interested in doing more research on and putting together a return to exercise sport protocol postpartum. Ideally, when you get a postpartum patient in clinic who is coming in specifically with musculoskeletal complaints associated with being in that postpartum state, one of the main things to do is to really evaluate the patient's core stability, general mechanics, especially with various single and double-legged movements, and inquire about general exercise that they're doing to build up to return to their sport. The postpartum resumption of physical activity really is an individualized process. Given the scant data, there's really no studies indicating that rapid resumption of activities is associated with adverse outcomes. But however, because most postpartum women have a degree of deconditioning, the thought is that for a gradual resumption of exercise. And this phase clearly requires additional research. Most studies have shown that many of the physiologic changes that occur during pregnancy return to normal within 8 to 12 weeks postpartum. The barriers to exercise postpartum are very similar to those during pregnancy. So again, you have a lack of support, knowledge, guidance, especially regarding breastfeeding. There's a lack of time. You have a newborn. And again, if you have other children, pain is a big issue. Lumbopelvic pain, again, specifically, patients will have a rectus diastasis. Maybe they're having some intra-articular or extra-articular hip pain. And then another big issue is postpartum urinary incontinence. So finally, if we look at exercise and breastfeeding, what we do know is that breastfeeding, what we do know about breastfeeding and sports participation is that there's no evidence that exercise or sports impair milk production or milk quality. I think that's a big thing. Breastfeeding women really should make sure that they're getting appropriate food and fluid intake, and there's guidelines on that. With respect to comfort during exercise, the usual recommendation is for breastfeeding women to consider feeding your infant before exercise or pumping before exercise to avoid the discomfort associated with breast engorgement during exercise. And supportive bra wear is also recommended. So my take-home points are the following. There's really been a foundational shift in our view of prenatal physical activity from minimal exercise to recommended behavior to improve quality of life, to specific prescriptions for physical activity to reduce pregnancy complications and optimize health across the lifespan of 2 generations. In the absence of obstetric or medical contraindications, physical activity in pregnancy has been found to be safe and desirable. So many of the concerns for regular physical activity during pregnancy being that they may cause miscarriage, poor fetal growth, musculoskeletal injury, or premature delivery have not been substantiated at all for women with uncomplicated pregnancies. All women without contraindication should be physically active throughout pregnancy, including women who were previously inactive, women diagnosed with gestational diabetes, women categorized as overweight or obese. Physical activity and exercise in pregnancy are associated with minimal risks and have been shown to benefit most women. So some modifications, as I mentioned earlier, to exercise routines may be necessary because of the normal anatomic and physiologic changes and fetal requirements that occur in pregnancy. Pregnancy really is an ideal time for behavior modification and an adoption of a healthy lifestyle because of the increased motivation and frequent access to medical supervision. Exercise should incorporate a variety of aerobic and resistance training activities to achieve greater benefits, again, with the goal of 150 minutes per week of moderate intensity activity spread over at least 3 days a week. For the elite athlete, there is really minimal information regarding the safety and benefits of high intensity, long duration, or extreme volumes of exercise. So more research is needed in this area. Additional research is needed to study the effects of exercise on pregnancy-specific conditions and outcomes, and to clarify the optimal type, frequency, and intensity of exercise. So these are my references. And thank you, everyone.
All right, that was wonderful. I think my favorite thing that you said was calling pregnancy a major musculoskeletal event, because I think that's just so true, and it often doesn't necessarily get the credit that it deserves. To kick off with the first question, one of the questions is, are you aware of any literature discussing weightlifting during pregnancy and any particular restrictions as it pertains to the weightlifting?
Yeah, so the literature on weightlifting, one, it is recommended. So resistance training, strength training is recommended for females to kind of continue in pregnancy, but there hasn't really been. We don't know what the risks in terms of maternal and fetal outcomes are in terms of heavy weightlifting or explosive weightlifting. So there's still really sparse literature in regards to any kind of guidelines with respect to resistance training. So we usually recommend that females don't lift too heavy, but resistance training definitely is a positive to be continued in pregnancy. But it definitely is an area that still needs more research in terms of specific guidelines, especially for our either patients who lift heavy prior to becoming pregnant or our professional and elite athletes who also tend to lift heavy when they're out of season.
Yeah, great. Definitely more research needed on that. And I think with a lot of the movements of women being more actively involved in some of the professional weightlifting, hopefully we do see some more of that coming down the pipeline. Mm-hmm. I was also wondering if you wouldn't mind just talking about how you would educate a patient who was previously in a sedentary lifestyle, but is now pregnant and kind of taking that optimal time to make a lot of many healthy choices, how you might educate her on starting her exercise program during her pregnancy.
So, being a sports medicine physician, if they end up in my clinic, it usually means that they're having some sort of pain potentially, right? Unless I'm doing some sort of preventative, outreach kind of thing. But, when it comes to exercise prescription, especially when you're starting off with somebody who has not engaged in exercise and really isn't familiar with a lot of exercise techniques and whatnot, I usually recommend that they work one-on-one with a physical therapist, one of our physical therapists who are knowledgeable about what the different changes are in pregnancy. So we have a lot of physical therapists who are interested in women's musculoskeletal health. And so I think that's a great place to start off with, is working with somebody who can take the time to make sure that they're teaching them good techniques and know how to start slow and progress up. In terms of with aerobic exercises, it really kind of depends on what they have access to. If they have access to some low impact exercise equipment like a stationary bike or a recumbent bike, that's usually a great place for them to start to at least kind of get moving. And I always have them start slow and make sure that they reassess their symptoms in terms of pain and within 24 hours. So if the pain is pretty significant and lingering into the next day, then they probably have started off doing too much. And so we need to kind of back down and start a little bit slower. But I don't usually have them going out to the gyms themselves and starting weight training, that kind of thing, especially if they don't have, that under their belt and are pretty green with respect to exercise in general. Sometimes I recommend that they start walking, but, here in Atlanta, which is where I am currently, right, at Emory, we have a lot of hills and whatnot. So usually the terrain really isn't the best for patients who are just starting to try to walk, especially with all the musculoskeletal changes that occur with that increased center of mass. And so if they have access to a treadmill, I always recommend that they keep it flat and don't put it on an incline. And we do a lot of trails here that are pretty flat. So walking also can be a pretty cheap activity that can at least get people moving.
Yeah, absolutely. And I was also just going to add to that, which you touched on, making sure, because the center of mass changes and the gait changes and there's some instability just with ambulation, if someone's previously sedentary, they might not have as strong of proprioception as other individuals. So walking on a flat surface or doing stationary biking rather than road cycling where you're at risk for falls. I don't think we often necessarily consider bicycling a fall risk sport, but that would be one of the things that could potentially be contraindicated in pregnancy just because of that risk. Another question came in, and it was just to if you are someone who is choosing to monitor your heart rate, is there a specific percentage of the heart rate max that is evidence-based for either fitness of the pregnant mom, but also in terms of maintaining adequate fetal perfusion?
Yeah, so there's been some studies that have, a few studies, not a lot, that have kind of looked at pregnant women who were in the low risk category in terms of looking at different heart rate changes in exercise and then putting parameters. Usually they kind of base it on, there are some that base it off of age of the pregnant female, some that base it off of the intensity of the exercise and what trimester you're in. And so those are some things that they're still lacking kind of data and even consensus in terms of, is this an adequate means of measuring heart rate, especially in a pregnant female. The more common things are some of the less objective measures, which with the Borg's rating of procedure exertion scale, or just like I mentioned, the talk test as an adequate, quick kind of test to be able to see what is what level of intensity are you exercising at, and kind of what to keep that threshold under.
Perfect. And then any recommendations that you would have in terms of treatment or therapeutic rehabilitation following diastasis recti?
So I think that, again, with diastasis recti, it's a common thing postpartum. 50% within 12 weeks of women who have most women, almost 90% of women who deliver are going to have some sort of diastasis recti. Within 12 weeks, the majority of, or I should say 50% of women has resolved. But even at 4, 5 weeks, 6 months postpartum, you still have as high as 40% of women who still are suffering from some level of diastasis recti. There's really been, the research so far really isn't recommending a lot of the abdominal exercises and more working on more kind of full body, core, plank type exercises. And so usually I send patients to one of my women's musculoskeletal health kind of physical therapists who can really help them try to engage their abdominal muscles and really work towards trying to get that to resolve. And at times, we'll get patients in clinic and we can use multiple musculoskeletal ultrasound to really measure it. But of course, that's just adding more data and not necessarily, helping resolve the diastasis. So most times I do send them to a few of our women's musculoskeletal health physical therapists for that.
Yeah, that's really interesting to measure the degree of diastasis with ultrasound. It's another great use of it. So I hadn't thought about that. Well, I think those are all of the questions that we had, but really, really great participation and an excellent lecture. So I don't know if you have any parting thoughts or comments or questions, but I'll turn the floor over to you.
Well, thank you all for listening, and I think that it's a very unique and evolving area, that there's so much more that we need to learn that can really affect a lot of females. And so I definitely think that it's an area, if anybody's interested in, that we need more people who are interested in, doing research regarding various aspects of women musculoskeletal health. There's a lot of other nuances and complications that go into it, especially, with the influence of the hormones and just menstrual cycles and everything, in order to kind of get concise and applicable data. But I definitely think it's an area that we need more people interested in and more research.
Wonderful. Well, thank you so much. Again, this is a great topic, not only for our future or for all their future careers, but also CAQ, very pertinent to know kind of those physiologic changes are often on the board exams, as are the kind of relative and absolute contraindications. But hopefully, as you mentioned, we see some change in those in the future. So we get more women active during their pregnancy. But thank you so much.
Thank you, Julie. Thank you very much.